Good day. Welcome to Gastro 4, Malabsorption Syndrome. I am Dr. Sarabeth De Castro. Our objectives is at the end of the lecture, the student must be able to diagnose malabsorption syndromes and manage children with malabsorption syndrome. Food assimilation is the major function of the gastrointestinal tract. Most nutrients cannot be absorbed in their natural form, and for this reason, they need to be digested. Food is chemically reduced to digestive end products, and that is small enough to participate in the absorption process across the epithelium of the intestinal wall. So in order to understand the pathophysiology of malabsorption, we must know the normal steps in digestion and absorption. Two physiologic changes in normal intestinal assimilation are hydrolysis and solubilization in the lumen at the enterocyte membrane and absorption across the intestinal mucosa into the systemic body fluids. This slide shows the part of the intestine where the different substances are absorbed. Let us briefly look at the small bowel length between 200 to 250 centimeters at birth, but it can grow as 300 to 800 centimeters in adults. With regards to absorption of different nutrients or substances in the duodenum and proximal jejunum, the following are absorbed. On the other hand, with regards to the macronutrients, most carbohydrates, proteins, and water-soluble vitamins are absorbed in the proximal 100 and 200 centimeters of small intestine, while throughout the small intestine, absorption of monoglycerides, fatty acids, and medium-chain fatty acids is possible. Lastly, vitamin B12 and bile acids are only absorbed in the distal ileum. The structure responsible for the absorption of macronutrients and micronutrients in the intestine is called the villus. These villi are projections within the lumen of your intestine, and the enzyme-producing cells are usually located at the apex of the villi. There are hundreds of projections of these villi within your intestinal wall, and within each villus is a capillary bed and modified lymphatic capillary called lacteal. The digested food are absorbed through the mucosal cells in both the capillary and lacteal. This diagram shows the histologic and endoscopic appearance of your villi. Height decreases if you have flattened villi, and it has reduced absorptive area and probably loss of digestive enzymes. Malabsorption can result from a defect in the nutrient digestion in the intestinal lumen or a defective mucosal absorption. It can be categorized based on a generalized mucosal defect and malabsorption of multiple nutrients. Let us see how malabsorption happens. Hydrolysis is the basic process of digestion. Carbohydrates, fats, proteins undergo digestion by hydrolysis. The difference between the three macronutrients lies in the enzymes and required to promote the digestive reaction. It involves also the process of solubilization, intestinal motility, and hormone secretions. After digestion, it will then be processed and absorbed at the level of your enterocytes. These are then transported to the blood and the lymph to be stored and metabolized as needed. Any disease that interrupt the sequence of these reactions may result or may lead to your malabsorption syndrome. This table shows the different malabsorption disorder that is associated with a generalized mucosal defect. On the other hand, this table shows malabsorption based on the different nutrients that are malabsorbed. In malabsorption, we have to know the different classes of nutrients that are basically affected. Management for each case will be directed towards the malabsorption of the specific nutrient. In infancy, lactose accounts for most of the dietary carbohydrate, while in older children and adults, starch makes up most of the ingested carbohydrates with smaller amounts of lactose and sucrose. Carbohydrates can be divided into four major groups. We have lactose that can be hydrolyzed to glucose and galactose. Lactase is the sole enzyme responsible for its hydrolysis, and this is usually located in the brush border of your enterocytes lining the villi of your small intestine. Activity is the highest in the jejunum and decreases towards the ileum, and usually it begins to decline with advancing age. This is the digestion process of carbohydrates. Amylose is non-branching, derived from animals and the simplest form of starch. Amylopectin have highly branched chains and came from plants. Digestion of carbohydrates starts in the mouth. Saliva contains mucin, a slimy glycoprotein important for lubrication, and rich in thiolin, which is an amylase that participates in the hydrolysis of starch. Amylase also participates and produced by the pancreas. Each specific carbohydrate have a corresponding enzyme responsible for further digestion. Further digestion occurs in the small intestine with your glucoamylase. Monosaccharides are then transported to the enterocyte and to complete the process of your absorption. Highest concentrations of these enzymes are at the villus tip of your jejunum and persist throughout most of the ileum but not in the colon. These boxes in the lower portion of your diagram corresponds to the different diseases in which absorption can be interrupted, leading to malabsorption. The most common type of carbohydrate malabsorption is caused by intestinal lactase deficiency. It can be divided to congenital lactase deficiency, which is rare and associated with symptoms occurring short time after birth when lactose is present in the diet. Adult onset is extremely common and normal for most humans because 90% are common among Asians and lowest among non-Hispanic whites, which accounts only for 15 to 25%. It can begin as early as 2 years of age or as late as adolescence. Most common is ethnic-related lactase deficiency. And lastly, secondary lactase deficiency can occur in the following an infectious gastroenteritis or injury to the intestinal mucosa caused by gluten or other sensitizing substances. Once you have malabsorbed carbohydrates, it can lead to watery diarrhea because of the osmotic gradient that drives water back to the lumen. Some may reach the colon, in which it can be fermented by colonic bacteria to your short-chain fatty acids, but if it's too much, it can lead to cramping and bloating. Lactase recovery may take months, and this is the last disaccharide to return to normal. How about lipids? The digestion, absorption, metabolism are not well developed in the newborn with regards to lipids, but the fat content of human milk is ideally suited for the newborn. That is why we have less malabsorption of lipids, especially if baby is breastfed. It is to note that more than 90% of ingested lipid in the diet is in the form of neutral fats or triglycerides, with small amounts of phospholipids, cholesterol, and cholesterol esters. It is called triglycerides because it has 3 fatty acids with a glycerol backbone. We are aware that triglycerides is the main dietary fat throughout life, and this applies to infants as well. Digestion occurs initially in the lumen by lipase and colipase, bile salts combined with digestive process to form the mixed micelles. These micelles are then presented to the transport proteins or your ATP binding cassette, which mediate its transport to the brush border. Uptake of your cholesterol and triglycerides occurs in the basolateral membrane. On the other hand, the bile salts are presented to the enterocyte to your ASBT, and uptake in the basolateral membrane then occurs. After uptake, it will return to the enterohepatic circulation or your bile acid pool, and the cycle continues. Any interruption in this process or in any situations can lead to malabsorption of your fatty acids. The release of fatty acids in the intestinal epithelium is potentiated by the release of your CCK at the sphincter of Oddi. Among the different enzymes, lingual lipase and gastric lipase are responsible for the 50 to 70% of fat absorption, and pancreatic lipase becomes fully developed at 2 years of age. Malabsorption of lipids mostly involve diseases of the pancreas. The most common cause of pancreatic insufficiency is cystic fibrosis. It is a triad of your malabsorption, failure to thrive, and chronic sinopulmonary symptoms. Most malabsorption of lipids can contribute to weight loss and malnutrition, and one may also have deficiency of your fat-soluble vitamins. Some may also have manifestation of diarrhea or steatorrhea. We are done with carbohydrates and lipids. How about proteins? Proteins are identified as the building blocks. Protein digestion begins in the stomach under the influence of your pepsin. Initially, this enzyme is in active form, but activation is catalyzed by the duodenal surface enzyme known as your enterokinase, which converts trypsinogen to trypsin. Bulk is hydrolyzed by pancreatic proteases that are secreted in the proximal duodenum. In order to hydrolyze proteins, we need the endopeptidases and exopeptidases. It will convert the dietary proteins to your oligopeptides. The brush border peptidases then hydrolyze it further to di or tripeptides and larger peptides. It will then be absorbed at the brush border. In the cytosol, they are cleaved to single amino acids, and uptake will follow at the basolateral membrane. Any process or any interruption in this process will lead to malabsorption, and the following diseases may be seen among those with malabsorbed proteins. The clinical manifestations of patients with protein malabsorption are the following: edema, diminished muscle mass, recurrent infection, weakness, muscle atrophy, and deformities in the skeletal bone. We have discussed the 3 macronutrients. Now let us proceed with vitamins. The fat-soluble vitamins are your A, D, E, and K. The fat-soluble vitamin deficiency is secondary to malabsorption of your fats. One may have impaired micelle formation due to bile salt deficiency, but symptoms will always be a vitamin-specific. The following are the common manifestations of your vitamin deficiency in fat-soluble vitamins. In vitamin A, patient may have follicular hyperkeratosis, vitamin E, demyelinization of your CNS, vitamin D, osteopenia or rickets, and vitamin K deficiency may manifest as easy bruisability, bleeding, either in the nose, gastrointestinal, vagina, or even bladder. Let us proceed with your water-soluble vitamins. Vitamin B12, cobalamin deficiency, may develop from those with strict vegetarian diet because meat is one primary source of your cobalamin. Those with pancreatic insufficiency are also prone with this deficiency, and those with ileal resection because active absorption only takes place in your ileum. How about folic acid? The source of your folic acid usually are from the dietary folates such as liver, yeast, vegetables, and some fruits. Folates are hydrolyzed to monoglutamate form at the brush border by enzyme folate conjugase. Any interference at the brush border can impair absorption of this vitamin. Iron. Absorption of iron takes place in the duodenum and the proximal jejunum. The amount absorbed is highly dependent on the total iron body stores and the rate of erythropoiesis. Any disease associated with the atrophy of the mucosa of the small intestine may lead to its malabsorption. And lastly, for the minerals, we have calcium. Absorption occurs mainly in the proximal small intestine and it is dependent on the vitamin D intake. Same with previous mineral, any disease that is related to mucosal defect of the intestine may cause malabsorption. Let us discuss the approach in any patient with suspected malabsorption syndrome. It is always important to plan your clinical approach towards a specific diagnosis. A detailed history must look for symptoms of diarrhea, abdominal distension, weight loss, and poor growth. Though these are non-specific findings, it can help you narrow your differentials. Let us further discuss important points in the history. The following are the important aspects to look at the history: the chronological description of symptoms, assessment of the appetite, activity, and sleeping habits, and dietary history is necessary to assess intake prior and during the malabsorption syndrome. Other important points in the history are taking note of your perinatal history, because if the symptoms are present at birth, or any history of serial infection such as immune deficiency and cystic fibrosis must be ruled out. Ask for any history of travel. Ask for any symptoms that may suggest IBD or inflammatory bowel diseases or liver diseases, or any genetically determined infection or disease. Some rare causes of diarrhea may be present early in infancy age, after introduction of your food, which may provide a diagnostic clues for sucrase isomaltase deficiency. You may also check the nature of the diarrhea. Is it explosive, loose, or bulky? Looking for the symptoms such as diarrhea and abdominal distension may help us diagnose or narrow down our diagnosis. Next will be asking the question of is it congenital or acquired, and what is the possible malabsorbed nutrients. Look at the physical examination findings that can guide you toward a specific disorder. Attention should be given in plotting the growth curve of these patients and look for muscle wasting, disappearance of subcutaneous fat with loose skin folds, edema, and look at other nutritional consequences that are dramatic among patients with malabsorption and malnutrition as well. These are the manifestations or findings that are nutrient specific for your calcium and vitamin D, vitamin K, and iron. How about diagnostics? What to request among these patients? For patients with suspected carbohydrate malabsorption, one may request stool pH, in which if it is less than 5.5, it may indicate short fatty acids in the stool. Other tests for carbohydrate malabsorption are breath hydrogen tests, which reflects passage of carbohydrate in the colon and its fermentation, and small mucosal biopsies. It can measure the disaccharide directly, but it is more of an invasive procedure. For fat malabsorption, the simplest form of fecal test is Sudan staining, the presence of fat globules in the stool, or check for associated deficiencies for your fat-soluble vitamins. You can measure serum concentration of your vitamin A, D, E, or even request for prothrombin time to assess vitamin K deficiency. For protein malabsorption, excessive bowel protein loss may manifest as hypoalbuminemia, but we have to rule out other possible causes of hypoalbuminemia, including liver diseases and inadequate protein intake. Alpha-1 antitrypsin has same molecular weight with albumin, but excessive loss in the stool should prompt further investigation. Let us briefly discuss some diseases that are associated with your malabsorption. This disease is rare in Central Africa and East Asia, but this is an immune-mediated systemic disorder that is elicited by gluten and related prolamins. Celiac disease is usually triggered by ingestion of wheat gluten, and specific antibodies for this disease is HLA-DQ2 or DQ8. In celiac disease, there's an altered processing by your intraluminal enzymes that led to changes in intestinal permeability and activation of your innate immune mechanisms. Common gastrointestinal symptoms within the first 2 years of life are as follows. How about liver and its biliary disorders? It can also cause malabsorption. Because you have impaired blood flow, it can lead to malabsorption of long-chain fatty acids and fat-soluble vitamins. Further malabsorption of these substances can eventually lead to your malnutrition. As I have mentioned, absorption of your fat and fat-soluble vitamins are highly dependent on your adequate bile flow, providing the bile acids to your small intestines. In primary bile acid malabsorption, there is mutation at the ileal sodium bile acid transporter SLC10A2 that results to steatorrhea, interruption of your enterohepatic circulation of bile acids, and reduced plasma cholesterol. What is steatorrhea? It is due to the reduced bile acid pool that will require restriction of your dietary fat. On the other hand, in secondary bile acid malabsorption, this can result from an ileal disease such as Crohn's disease or ileal resection. Now let us proceed with short bowel syndrome. Usually, this results from a congenital malformation or resection of your small bowels. This table summarizes the causes of your short bowel syndrome. In short bowel syndrome, there is a loss of more than 50% of your small bowel, with or without portion of your large intestine. Usually, this results in symptoms of generalized malabsorption or other specific nutrient deficiencies. The factors to consider are your length of the bowel remaining and the location of the resection of your small bowel. If the following are preserved, it has the best prognosis. You have duodenum, distal ileum, and ileocecal valve. Management of patients with short bowel syndrome is mainly focused on the repletion of the massive fluid and electrolyte losses. Monitoring the ostomy or stool output should be adequately checked. Intestinal adaptation is possible in most patients, but nutrition support may also include giving parenteral nutrition or trophic enteral feeding. The following are the associated complications, and among those with ileal resection, it is important to take note that supplementation of vitamin B12 is necessary to prevent its deficiency. Another disease to take note is your eosinophilic gastroenteritis. It is characterized by patchy or diffuse eosinophilic infiltration of your gastrointestinal tissue. 50 to 70% have history of allergic diseases, but this is diagnosed based on histologic findings. The most common site affected with eosinophilic gastroenteritis are stomach and small intestine. Malabsorption can occur if there is small bowel involvement, especially in patients with extensive villus blunting. How about inflammatory bowel disease? Malabsorption in IBD occur as a result of small intestinal involvement, resulting from the decreased absorptive area, and symptoms may include weight loss, chronic malnutrition, and macro or micronutrient deficiencies. For post-infectious diarrhea, also symptoms can be associated with malabsorption. It can appear following an infectious enteritis, and the pathogenesis may be related to secondary lactase deficiency. Infections with the following organisms may also present with symptoms of your malabsorption. Chronic disorders. Chronic disorders can present with diarrhea leading to further mucosal damage. This results from decreased food intake, malabsorption syndrome, and increased nutritional needs, especially for patients with chronic diseases. Management will be identifying the specific disease and applying the specific treatment. We have to treat and prevent malnutrition, and we have to provide adequate nutritional support. Management will include providing adequate nutrition, which will include enzyme supplementation if necessary. Thank you, and please remember all these concepts for our small group discussion.